clinical practice, he has consulted more than 5,000 patients with diabetes. His active area of interest is individualized diabetes care, diabetes remission, diabetes prevention, and the use of technology in managing diabetes. He is attached to Apollo Spectra Hospital, Tadeo, and various other clinics in Mumbai. He is also actively involved in online consultations for diabetes for patients who do not wish to come for a physical consultation, and has consulted nearly 1,000 patients online during COVID-19. He has also contributed to research and medical writing in the form of chapters in textbooks, research articles, and articles related to awareness of diabetes and its comorbidities. Uh, we, okay, now let us keep this question answers at the end of the session. Doctor has agreed that he will give us time for 10 minutes for question answers. Okay. So now I now present the speaker of the day, Dr. Bhavik Saglani, with great applause. Doctor, you can take the platform.
Thank you so much to everyone who is attending this meeting on a Saturday evening during these times. And thank you for inviting me. I have previously given a couple of talks to Lion Club. I don't remember the area, once in Matunga and once also, I think the Cuffe Parade group or someone at PVM Gymkhana.
At PVM Gymkhana you had given.
Yeah,
yes.
I had given one. So initially when, I spoke to Ms. Jiru, I told her we'll talk more on stress and diabetes, but then I've made my presentation such that I cover a bit of everything, because then I thought that people have been so stressed out already that we'll talk about stress, but we'll talk a little bit about everything so that it doesn't stress you out even more. So I've made something where you can take home some simple messages, for yourself, your families, and your loved ones. And I always believe in diabetes management by involving the people, by involving people, making them the foot soldiers of diabetes prevention. So when you empower one person, when you educate, not necessarily the person has to be from a medical background. Someone who's an engineer, someone who's a homemaker, anyone, if they have adequate, simple knowledge about diabetes and diabetes prevention, I think they can pass on that factual knowledge, because there's a lot of misinformation also that goes on, especially on social media platforms. So I'm just going to share my screen so we can jump into the presentation right away, and we can start with that. So what I have actually made something. Yeah, I hope you can see the screen that I've shared, everyone.
Yes.
Yeah. So I thought of, labeling this as 20 points on diabetes in 2020. We've all heard a lot about 2020, how this year has been, quite terrible for some and stressful for others. And it's been a hectic year for most people due to COVID and its resulting complications in everyone's life. So I've made 20 slides and 20 key points on diabetes, right from what is diabetes to how we can manage it. And I will include the core topic of the day, that is stress and diabetes and COVID and diabetes, somewhere in between this. So if we understand what is diabetes, that's probably the first point. In simple terms, it is a chronic metabolic condition in which your body is unable to produce enough insulin. Insulin is a hormone which is made by the pancreas. It works like a key. So if you see that small diagram, maybe it's a little too small, but insulin actually acts like a key. It opens the doors for the sugar, that is glucose in your blood, to go into the cell. So it doesn't remain high in your blood vessels for a longer period of time. So it's like a chabi. It opens the lock, lets the glucose from the blood, the extra glucose from the blood, go into the cells, and depending on your metabolism, your diet, and your physical activity, that glucose is either utilized as energy or it may be converted into fat, or it may be stored in a concentrated form of glucose. So this is a basic of diabetes. Glucose levels go up in the blood because either there aren't enough keys to open enough doors, or the key is not smoothened enough. So either the insulin is not secreted properly, or the insulin is not functioning properly, or a bit of both. So this is a basic of what happens. It's a very simplistic explanation, but this is sort of a basic thing. Types of diabetes, people usually have this question, right? Anyone who has diabetes, whether it's type 1, type 2, what is type 1, what is type 2? So broadly, type 1 diabetes is insulin deficient. Your body, for some reason, is not making insulin at all, or there is an autoimmune reaction in which your body's own cells have attacked your pancreas for some reason. This usually happens in children and younger adults, although it can be diagnosed even in adulthood or at a later age. So that's type 1 diabetes. This is mainly insulin deficient. This constitutes to less than 1 or 2% of the total diabetes cases in India. This is slightly more common in Europe than in India, but we do have a lot of children. And it's sort of, the insulin is the only treatment for this, although now there are advanced modes of administering insulin. Earlier we had to give different types of insulin. Now we have an insulin pump which can automatically give insulin. So there's a lot of technology that is developed, but that's type 1. And if I'm referring to anything during this talk, I'll be referring more to type 2, because we have 95% cases, or 80 to 90% cases in India are type 2 adult onset. That's very common. Earlier, we said that the age of onset was 40 to 50. Now that age has come down to 30 to 40. So we are seeing this in younger adults, and that's a big problem, right? Because someone who's diagnosed with diabetes at the age of 30, with people, the life expectancy in India is slowly going up. Yeah, I think about 68, 69 on an average, and that's likely to go up even more. So it's about 4 decades of living with diabetes for someone who's diagnosed at the age of 30. So how do we manage that case? So type 2 diabetes, the commonly seen diabetes in adults, that's type 2. Then there is something, diabetes that happens in pregnancy, that's called gestational diabetes, which in pregnant women, that's also increasing because of later age of pregnancy and because of PCOS. It's like a complete spectrum. And then there are other types of diabetes which do not perfectly fit into type 1 and type 2. So sometimes you are an adult and yet you require insulin initially. That's something we call type 1.5. There are technical terms for it, but I'll stay away from technical terms and try to make it as simple as possible for everyone. So type 1 in children, younger, treatment is insulin, not as common, but is still there. Type 2, the most common type, adult onset usually, but we are also seeing in younger children, even 18 to 20-year-olds are now presenting with early onset type 2. And gestational is pregnancy diabetes. It's important because a lady who has had high sugar levels during pregnancy is much more likely to get it later on in life. So it's like it's like a reminder to her. It's like an opportunity to her, I would say, that you look at, don't look at that as a something that why did it happen to me. That's an opportunity. You know that you're more likely to get it after delivery. You can work towards trying to prevent it in the future. Symptoms is a confusing thing. A lot of people come to me with 250, 300 sugar levels, and they just simply say, I have no symptoms, doctor. How do I have? The lab report is incorrect. I want to check again. And they go to multiple labs, they check. It's good. You have to probably confirm it once or twice. But that's something patients usually do. They don't believe because they don't have those symptoms. And the symptoms are also sort of, they tend to coincide with other symptoms. So increased frequency of urination may be a symptom of urinary tract infection. So weight loss, maybe everyone feels that, they are stressed, or they are, in some sort of situation where they can lose weight. I mean, 70%, there's a study was done globally, and it said 70% people are trying to lose weight. So when you lose weight, you feel your efforts are bearing fruit, but sometimes it could just be hyperthyroid or diabetes. Always hungry, always thirsty. These are all symptoms that come at a level of above 200, 250 for a longer period of time. Genitourinary infections, very common in women. That's how most diabetes cases in women in India are diagnosed, not by a family physician, but by a gynecologist, because they go to their gynac with a complaint of itching in the private private areas, and that's how it's diagnosed, and that's how you ask them. Blurring of vision, that's another symptoms. Wounds that don't heal, it's connected to diabetes, but also connected to impaired blood flow to the area. Numbness in the feet, that's very common, especially vegetarians who have a B12 deficiency and high sugar. The numbness in feet can happen, and sexual problems are also common. So these may not be presenting symptoms in many cases. The most commonly diagnosed diabetes are on those regular health checkups. So that's a little, but sometimes it may help you diagnose a little early, and that may help you prevent your diabetes. Now, diagnosis of diabetes, few points that few frequently asked questions to me. One is, how much is the duration of fasting? So fasting sugar, 8 hours is more than enough. Even if the laboratory person tells you 12 ghanta, you tell him, हाँ मैंने 8 hours of no caloric intake, water is okay. Random or oral glucose. So earlier they used to test by giving 75 grams of glucose in water and to be had over 15 minutes. But now we usually rely on this. And HbA1c, this is glycosylated hemoglobin, which is a 3 months average sugar test. So it comes in the form of percentage. Basically, your hemoglobin molecule, a single hemoglobin molecule circulates in the body for 90 to 120 days before destruction. So there is your sugar in the blood tends to stick to a particular part of that hemoglobin molecule, and that's how we can get an approximate of 3 months. A lot of patients ask me, okay, this 3 months average test, are you doing some magic? How do you know what my levels have been in the past 3 months? I said, no, the lab don't do any magic. This is scientifically how we do it. This is a very important test nowadays because it gives you a certain spectrum, right? Because sometimes you may just, some people are very good patients just before the tests. A week before the test, they are extremely well. They go for their walks and everything. So fasting and post lunch may be good, but when we see the average, we know something is missing. Urine sugar is another, parameter. Sometimes you do a test for a routine urine, and so these are the levels. Fasting less than 99 is not, or equal to 99 is normal. 100 to 125 is borderline, and more than or equal to 126, that's fasting. Oral glucose or OGTT can also be replaced with a post lunch. So 100 to 139 is normal, 140 to 199 borderline. So these are certain things. Similarly, HbA1c, but the important thing is you should never start treatment on the basis of a single test unless your symptoms are very severe. Someone's lost 15 kgs weight, urine in frequently, and a random sugar is 400. Yes, that is diabetes, but a single reading of 201 should not warrant to start treatment immediately. You have to recheck it. You have to probably do an HbA1c. You have to correlate with the symptoms, and that's where the clinician's role becomes important to avoid an unnecessary patient being medicated when he or she may not require it. Number 5 is pre-diabetes or borderline. This is important, excellent opportunity to prevent progression to diabetes. You can lose fat. I mean, you can lose weight and especially fat and try to maintain the lost weight. About 8 to 12% of weight lost in obese people can reverse diabetes. There are certain medications also which we give, but we rely more on lifestyle modifications. This is especially important in younger individuals with a strong family history, right? If the mother and father both have diabetes, I would say even 30 is a good age to start testing. I mean, you can just do a random test. It doesn't even cost much, but uh, you will know at least if you are in that borderline range, and you can take some precautions then, because you start testing typically after 45, 50. As I said, symptoms are not too, above below level of 250, 300. You don't get those classical symptoms. You may just keep losing weight, and then after 5 years, when already there's some damage to the organs, is when you are testing. So strong family history, people, or some of one of these symptoms, you should test regularly. And it's good for all. It's good for the individual. You start your treatment early, we can manage you without medications or with minimum medications. Family, healthcare burden on individual and on the economy per se, because in the West now a huge spending is on diabetes management, which we cannot frankly afford to reach that stage. Investigations, yes, glucose tests, as I discussed in the previous slides, where 3 months average fasting post lunch. Creatinine gives us a reflection of kidney function test. To start medications, we need to know that. Eye screening, this is important. Once in a year, you should get your eye screen for any early changes in the retina. You may not get eye disturbances earlier, but there will be something budding there. And by the time it comes in the vision threatening area, it may be too late to salvage everything. So eye screening once in a year is extremely important. Blood pressure is another very important parameter for the bigger organs, the heart, the brain, the bigger arteries. Blood pressure control and lipid control is even more important than diabetes. And the smaller vessels, that's the kidney, the eyes, and the nerves, that's where the diabetes control becomes more important than blood pressure. But all three, I call them Amar Akbar Anthony: diabetes, blood pressure, and dyslipidemia or deranged cholesterol levels. All three need to be controlled properly for a holistic overall treatment. Foot screening, sometimes we hear of people getting gangrene or wounds in the foot non-healing. So we need to see the sensation and the blood flow. We can do that either by a clinical examination, or now we have certain machines that help us test or check how much blood flow is going to the smallest artery of your feet. Treatment options, this is important. The most important thing, diet. There's a lot of talk about diet, this diet, that diet, keto diet, intermittent fasting, Mediterranean. There are like hundreds of diet fads, and some of them are actually good. But what works for you, what works for your family, everything has to be so. Practical diet modification, I think the most important question that a doctor or a dietitian needs to ask a patient is who cooks for you and for how many people. We often don't ask that. We just say you in the morning, you have you stop all this that you are having, and you have this, you have oats and all of that. But you don't ask who's cooking at home. If there's one person who's cooking for 5 people, and you suddenly ask that person to cook specially for one person, are you calculating, are you taking into account the changes that are going to happen? That person is going to do it because one of the family members has diabetes, and the doctor has said, or the dietitian has said to do it. But if you know that that one person is cooking for 5 to 7 people, then you will probably offer more practical solutions where that person who's cooking at home does not get overburdened with it, because that may not be sustainable. There may be other complications that may enter into that family fabric. So that is something I believe it's important. Diet may be of different types, but you need to know who cooks, and then you need to do a practical routine. Exercise routine with an individual can follow. There is no point telling someone who loves doing, Zumba, or who loves dance as an activity to go for a walk. The person will get bored of it. So you need to spend a couple of minutes to know what the person or the individual liked. If they had any hobbies which were related to any physical exertion, someone liked a sport, you can encourage that person. Right now in COVID times, it may not be, but 6 months, 1 year down the line, we may be back to what things were. So exercise routine which a person likes and can follow long term. Stress management, this is where we'll come to again, extremely important. I think stress management goes into two parts. There's a separate slide for that, so I'll talk about it that time. Similarly, with oral medications and insulin, there are separate slides for it. A regular follow-up is important, and that may be after, for some cases where we are starting insulin, that may be after a week. Some cases where patients are very well controlled, it may, on minimum medications, it may be 3 to 6 months. Someone who's well controlled only on diet and exercise, it may even be once in a year. But a regular follow-up, depending on your case specifics, is important. Taking a relative along, now this is a tricky situation. A lot of people come alone, they tend to, but I believe that if it's possible, when you're consulting a doctor, you get a guardian along. It helps sometimes realize, and sometimes some misunderstandings about medications are also sorted, because the person who's probably, if 2 people, there may be certain misunderstandings and certain things that can be better absorbed if there is someone. Continuous care is what I've said, regular follow-up, and asking questions to your doctor and dietitian. Yeah, I mean, I'm sure people will say that doctors don't listen as much, or they don't spend as much time, and these are all absolutely valid feedbacks that I get from patients. So that's something that even doctors need to work on, dietitians need to work on, is to listen to your patients, to encourage them to ask questions. If not at that consultation, at the next consultation, I tell my patients to, every time you have a question in between the consultations, you've met me once and you're going to meet me after a month, you have any questions, note them down on a piece of paper, keep a diary, and carry that along so that you don't forget. As soon as you enter the cabin, sometimes you get intimidated and you forget. The doctor is in a rush, you may forget. Keep the diary. That's what I do to my patients, and I hope more people can go to. Diabetes prevention. Yeah, see, prevention, we all know prevention is better than cure, but in diabetes, we put an A there. Prevention is better than care. I mean, you need to take care in order to prevent it, but the care to actually manage it with medications, with insulin, with higher levels is much more than a simple prevention. So it starts with encouraging. I think this should start with a very younger age. If we have to see any difference in the next 2 or 3 decades, we have to start encouraging kids again, providing them with facilities to pursue outdoor activities. Most of the kids are more on tablets and laptops and playing games, and even education has gone online. So it's difficult, but this is something that we need to at least give them a chance to pursue a hobby, like a hobby, and then probably persist with it even after adulting. Obesity in children is becoming a concern. That's one of the things that we need to look at. Are we the food that children are eating? How often are they eating the junk food and all of these things? High risk groups, identifying high risk groups. As I said previously, those with a strong family history of diabetes, polycystic ovaries, obesity, high blood pressure, sedentary lifestyles, and extreme stress. These are high risk groups that we need to target. Efforts needed to prevent diabetes will, in hindsight, seem minimal compared to those needed to manage it. So that's something that we always often see patients telling us. Diabetes remission or reversal, I like to use the word remission because reversal makes a patient more complacent, I think. But reversal, remission, both are possible. But we need to select and we need to give a realistic expectations to our patients. So we need to select the candidate properly and counsel accordingly. So remission is defined as once you are detected and then you are not managed. Then you are managed only with everything except medications. That would term as remission or reversal. On some cases, even metformin, that's a mild tablet, that is also termed as remission or reversal. But without any medicines would be an ideal thing to term it. Candidates for remission have to be carefully chosen or have to be carefully explained. Younger patients, those with a higher weight or fat percentage, those with adequate insulin secretion, we have a test that we know, and those who are extremely motivated to do this. These are the ideal candidates. So younger age group, those with a higher body fat percentage, those some people whose lifestyle is already very bad, you have more scope to correct it. So sometimes I get younger patients and I ask them, and they say, no, my lifestyle is completely absolutely fine. And then in a way they are very happy to tell me that, but in a way I'm like, okay, he's already doing 90% and yet he's got it. So someone whose lifestyle is bad at that time probably has a higher chance. So those who should not be uh, told or should not be encouraged to try this, or maybe try it in a stepwise manner, are older individuals, those who are on insulin, whose body's insulin secretion is less, and those with comorbidities like liver dysfunction, heart problems. They should not be encouraged because sometimes you may tend to go overboard with this, and there may be certain other adverse effects. Losing 8 to 12% of your initial body weight, different studies say different things, but and maintaining it can enable remission in a lot of obese cases. Important to continue monitoring. That's extremely important. You should not, once you reach those levels without medications, you stop monitoring even once in a month, once in 3 months. Then after a year or so, you're back where you were. As I said, should not be aimed for all, attempted in cases only under expert guidance. Diet and diabetes complex, I think we'll have some questions on it. But as I said, who cooks at home is important. We need to overall reduce our carbohydrate intake. Most of our Indian diet is very high in carbs, that is bread, biscuit, potatoes, rice, wheat. We tend to have 70% of our food. And I'm not saying we need to stop all of this. I mean, you can probably choose a better carbs, or you can reduce the portion size of the carbohydrates and increase the other things on your plate. So, whether it's salad or that's veggies or that's chicken or eggs made in less oil, or fish made in less oil. These are the things that you need to increase and try to reduce, especially for diabetes. You need to overall reduce. The good thing is our diet is so high in carb overall, that even a 20 to 30% reduction can get us good control. So that's my practical advice to my patients at the first step. Working towards stopping compulsive snacking. This is a little, especially at night when you're awake watching a movie, and you need to watch the best part is not to have those things at home that may encourage this, but this is something that we need to work towards. So exercise and diabetes, combination of aerobic exercises like brisk walking, swimming, running, and resistance exercises depending on one's routine. If someone's not used to doing them at all, you need to be under some trainer, or you need to probably watch a few good authentic people on YouTube. Like someone was saying, he's on YouTube all the time. You should probably go, and how to start a simple resistance, that is muscle training exercises. So this can be done for any age, but it needs to be done so very, you need to know a baseline, that how much the person has exercised, or what is the weight of the person, what are the other comorbidities. But the best is this combination of all three. It's aerobic, a little bit of resistance training, and something like meditation for the mind that helps calm your stress axis. Again, that's something that we're going to talk about in a couple of minutes. For diabetes management, 150 minutes exercise per week, divided into 3 to 5 training sessions. Someone does it every day, I'm more than happy. But you can have those practically a couple of days off in a week, and watch your diet on every day. That's something that probably gets, but exercise 3 to 5 days a week, 150 minutes as a total thing. You may even increase it, and the important thing is to increase it slowly. So if you're not used to exercising at all, even 15 minutes per day is good. Something called non-exercise activity is as important. That means when you're on a call, if you're just lying down or sitting, can you walk around doing that? A lot of younger people in their offices now have stationary cycles where they actually sit and they go ahead with their meetings on cycles. Especially in the West, this is common. In India also, some offices have kind of adopted this. So these are things that, when you're not exercising, can you increase your activity? Stress and diabetes, this is what we're going to talk a little, spend a couple of more minutes on this. The direct effect of stress leads to release of hormones. So insulin, as I said, is a hormone which is responsible for lowering or keeping your glucose in your blood in check. There are hormones which are counter to the action of insulin. They completely counter the action of insulin. So that's your body's steroid, or your body's own steroid hormone. There's a hormone called glucagon. So basically, these group of hormones are called counter-regulatory hormones, and all of them, in some capacity or the other, are increased in extremely stressful situations. So that's the direct effect of stress. You have hormones that are opposing the action of insulin. It is going to lead to increased glucose level. The indirect effect is stress leads to binge eating. That's how people trying to cope with stress. It makes it difficult for people to adhere to an exercise routine. So the two main pillars of diabetes management, that's diet and exercise, is something you can't concentrate on when you are extremely stressed out. You tend to resort to eating something that you usually wouldn't. That's a sort of a comfort mechanism, comfort eating or binge eating. You have to also figure out whether the stress is acute. So it's something where someone has passed away in the family. You can just cope with it little better. You're never going to be able to be, it may take some time. You may seek if the person is not being able to cope with it at all, you can seek help of a healthcare professional or a counselor or something if it's extremely bad. But the chronic stress is something that happens on a daily basis. Now this is where you need to find a solution. So if I'm unable to wake up every morning with my alarm, that is where my stress begins. And then I'm unable to find my car keys. I'm unable to, there's a car which is parked right, or there's a bike which is parked right where my car is parked, and every day I have to. So if this sort of chronic stress is there every single day, you have an opportunity to find a solution, but you are not concentrating on the solution, and hence repeated things are happening every day. So this is a effect of chronic stress, where you can concentrate on solutions instead of problem. Acute stress, time sort of heals it. People can help you deal with it better, professionals. But that's like a loss of a loved one. That's going to take its time, and there's going to be some impact. So this is what we need to identify. I think pursuing a hobby, time spent with near and dear ones, concentrating on solutions for chronic stress, meditation or mindfulness, even being mindful of your own breathing, even being mindful of what you're eating. These are simple mechanisms, not watching TV while eating food can help you, enjoy those things a lot better. Obviously, if the stress levels are extremely high, you're unable to cope with it with these simple solutions, you need to seek help with a healthcare professional, a counselor, a psychologist who will help you deal with it better. Oral medication, I'm not going to go into very deep. I'll run through this quickly. There are 5 or 7 types of different medications. Science has advanced. And one thing I want to emphasize, I do this at all my meetings, so probably it may be repetitive. There is no medicine for diabetes which will by itself. approved medicines, I'm talking about the approved ones, which will by itself cause kidney dysfunction. If the kidney is affected because of a kidney stone, because of urine infection, because of long-term uncontrolled diabetes, blood pressure, or any other cause, then we need to reduce the doses of existing medicines because they are excreted from the kidney. If they're not excreted in the same manner, they will accumulate in the body and their action will be doubled up. So the same medicine will act double and your sugar will go down. So a lot of time what happens, patients' creatinine levels are slightly high, whatever may be the cause. It may be a kidney stone, it may be infection, it may be long-term kidney injury because of high blood pressure, sugar, cholesterol, or any other cause that is hampering or affecting the kidney. When you go to the doctor, he tells you that we need to reduce these medicines. But sometimes maybe he doesn't explain it. Sometimes you don't, that communication is not effective. There are some misleading WhatsApp or social media forwards that tell you that diabetes medicines cause kidney dysfunction. And combine that with the fact that when you went to the doctor with a first high creatinine, he reduced two medicines. The first impression that goes in your mind is that this is happened because of these medicines. So that because effective communication needs to be done. Some medicine, so there are certain side effects. There are some oral medicines that may have a risk of hypoglycemia, that is low sugar levels. Some do not, some are milder. Some may cause weight gain, some are weight neutral, and some may actually help you to lose weight. So there are three types of medicine in terms of weight. There are certain other side effects. One class of medicines has an effect of urine infection, something may give acidity. So these are all minor things that we may sort out, but there are no major side effects in the approved ones because they are now well researched and studied, and we are very sure of the safety. Insulin, the first reaction of most patients is one of fear to insulin. But if it is needed, if your body isn't making adequate insulin or your sugar is extremely high, 400, 500, that is the time when you will need insulin. It will be your very good friend for some time. You may be able to stop it if your body pancreas, which is in a sort of a shock at that time with such high levels, recovers from it and starts secreting its own insulin in an effective manner. So there are cases where we give insulin short term, but there are cases which are not being able to control with diet, exercise, and three or more oral anti-diabetic drugs, and we put on insulin, that may be a long-term insulin. So that's one question asked repeatedly: Doctor, will my insulin be there forever? Will I be able to stop it? But that really depends. A newly diagnosed case with 500, I've put one case study where a young patient was with 400 sugar, and he's now on no medicine. So I had to give him insulin for that period. As he, as the initial period was worn off, his pancreas was again sort of, the pancreas goes into a sort of a shock. There's so much sugar, there's so much glucose in the blood that's trying to stimulate it to secrete insulin. Temporarily, whatever its capacity also, it does not. In simple words, that's how I can explain it. With technology, insulin pens, now we have easier methods to administer insulin. New insulins, we have decreased risk of this thing. The aim of diabetes management, this is important. I think health and happiness both together is the aim, not only. So that's important to know that the patient needs to be happy with what he's doing. To chalk out a treatment plan, keeping in mind the patient's routine, background, cultural importance, we need to keep these things in mind. Prevention is the ideal scenario. If not, then prevention of complications by effective management or prevention of food complications. Early diagnosis of complications, if at all complications unfortunately do set in. Important to manage blood pressure and lipids. This is a new technology, continuous glucose monitoring. I am using this actively. So there may be times during the day when your sugar is going 200 and there's time when it's going to 80. The average sugar will show as 140. But actually that 200, 220 excursions are what can long-term impact your effect on other organs and the complications. So there's this continuous glucose monitoring technology. We put a small sensor, just attach it to the back of your arm. It's a very small OPD. It's not a procedure also. It's just, you just put it here. It just sticks here with the help of an adhesive. And every 15 minutes, it takes a glucose reading. This goes on for 14 days. So that's about 96 readings a day. It's about 1300 readings plus in 14 days. When the patient comes back to us after 14 days or at the end of 7th and 14th day, we get graphs. We ask the patient to note down what they are eating, and we can correlate how food is impacting. We've seen some cases where rice does not increase sugar much in a small quantity. The same person has wheat, the sugar goes up. and there are other cases where wheat does not increase and it's there. So these simple questions we get asked in the OPD, whether rice is good or wheat. I said, it could be the simple answer would be that you reduce rice, but that's not the case with everyone. COVID-19 and diabetes. Good diabetes control can help patients cope better and recover from COVID. This is proven now. A good pre-COVID, someone unfortunately is going to get affected with COVID. If he has a good diabetes control, it helps recover and cope better. By itself, also COVID-19 can increase temporarily we've seen for 3 months odd. Steroid medications are a mainstay of treatment in moderate to severe COVID, and they immediately increase the sugar levels. So that's something patients may need insulin to cope with these increased levels during that period, and then you can come back to your original medications. Reduced activity, lack of exercise, and more calorie consumption has indirectly worsened overall diabetes control. So we've seen patients coming directly after November, December, Jan, Feb, directly now, and most of them have had a spike in their sugar levels because they've stopped walking much because due to the fear of contracting COVID outside. At home, most people are at home, so there's easy availability of snacks. So all of these things this is something I'm big on. Probably the world will gradually, India will also switch to this. Not completely, you need the physical consultations, you need the physical touch, but this is accessible for a 1 month follow-up. Patient has met me 1 month back. So this is something that we've had to take to during the pandemic, and this has been legalized in India. Thankfully, it took a pandemic for our medical associations to actually recognize that technology can be used. But now they've legalized it, and as I said, I've seen nearly 1,000 patients in new and follow-up combined during the past 8 months on with online consultations. And it's really simple, especially for diabetes. It may not be for things that need examination. You need to examine the eye, you have to go to the doctor. He needs those machines to see you, or an ENT needs to see your ear. But for certain skin conditions, diabetes and online care can be good. Once a year or twice in a year, a physical consultation is a must because we need to examine that personal touch needs to be there with the patient. But this is something the patient can ask more questions. I feel, it sort of gives that little bit more. Patient is not as intimidated sometimes as in a clinical atmosphere. Last two slides continues. This is something I do. Instead of doing a single consultation, I prefer patients to be at a 1 month, 3 months, 1 year, where every 15 days we pick a different topic. There are 12 topics that I speak on with the patient, or we have a conversation. All of these topics that I've discussed, including the complications, how to prevent them, it's virtually impossible to do everything in one consultation, even if it's 30 minutes. My first consultation is 30 minutes, but even if it's that, we cannot cover all bases. So continues, and generally at the next consultation you don't remember what you had spoken about and what you had not spoken about. Whereas a structured thing would help us counsel patients effectively. So this was a case that I was talking about in May 2019. I had a case with a 31-year-old guy, obese, 300 plus sugar levels. For post lunch was almost 400. We had to start him on insulin and oral medications. He was counseled regarding his age, that he was young, duration of diabetes is less, he's obese, he has a scope to reverse his diabetes or put it into remission in the long term. Although at that time it seemed like a tall task because we were starting insulin and medications both. He had lost a lot of weight. He wasn't feeling good at all. We did a 2 weekly telephonic consult. That time it was not legalized, but I was doing it just on as a as a trial basis. And every 2 weeks we had telephonic consultations to adjust his doses, even sometimes even more frequently. We could stop his insulin in I think it was 3.5 months, and slowly, one by one, he was on 3 types of medications overall, and we could stop everything in 1 year. Now he's in remission for a year, and he's lost about 10 to 12% of his initial weight, and hence this stepwise scientific approach is important for remission. I thank you all for a patient hearing. I'm sorry I exceeded by 5 or 10 minutes, but this was a comprehensive thing I wanted to convey. I'll stop my slide sharing now. Yeah.
Thank you.
Thank you.
If there are any questions, please go ahead. Unmute yourself and ask questions. Pawanji,
Yeah.
unmute everybody. Let them ask questions if they want to.
Yes, any questions, please? Anything. You can ask me anything. Don't
does the body weight increase in diabetic patient?
So usually, if the sugar levels are above 180, 200, more than
Okay.
200,
Uh,
typically glucose is excreted in the urine, and that is when patient may actually lose weight, but that's not healthy weight loss. That's because the glucose is actually spilling into your urine. Normally that glucose should be reabsorbed back into your bloodstream. So, but in initial cases, in those with insulin resistance, like less than 250 sugar levels or borderline diabetes, you may
okay.
actually gain weight because of a high insulin spike. So you may
Okay.
gain weight. There are certain medications, one or two types of medications that can cause weight gain in diabetes,
Okay.
as I mentioned. So that is the type where someone's on started. If you've been a medicine called pioglitazone, which can cause. So that's one of the medications that can cause. And otherwise, because of genetics and insulin resistance in someone whose levels are not very high, but above 200, you can actually lose weight because there is a lot of glucose excreted in the urine, which should not be as.
Okay. Thank you.
May I ask a question, doctor?
Yes,
Uh,
please go ahead.
yeah, I am 72 years old. I
Okay.
go for annual checkups. I
Yeah.
don't have diabetes right now. But is it possible that I may contract diabetes at a later age, after 75 or at the age of 80 or whatever, up to
Yeah.
whatever time I survive?
Yeah. So this is a good question. Actually, a lot of people have this question. Even my grandparents keep asking me this question very frequently. They are 85 plus now. Uh,
Okay.
so see, the simple answer is most likely you will not get it now, but we have still seen cases at the age of 82, 83 who get diagnosed with 200 plus. Also,
Oh,
what happens is after a certain age, the
yeah.
control levels are little relaxed. For a younger patient, I would like the levels to be very tightly controlled because the complications in diabetes come as a result of years of uncontrolled diabetes. So in someone who's 70 plus, 75 plus,
Yeah.
the levels actually get a little relaxed. So if we say that we diagnose diabetes at 6.5 HbA1c, for
Mm.
someone who's 70, 75 plus, I would relax that to 7%, 7.5%, and just ask them. So even if you get a mild type of diabetes at age, it may not classically fit into the diabetes definition. But more or less, 70 to 80% cases will not get it after the age of 75, 80. I mean, we see that they do not get it, but there are cases where it can be diagnosed at any age. The diagnostic levels may increase compared to a younger patient.
Okay. Thank you. Thank you.
Can I ask one thing?
Yes, please.
Sorry.
one sec, Cashew. Jaru,
हाँ बोल.
uh, Jaru, yes, for the evening, Mr. Lokhandwala is joining in. He is though traveling, he is joining in. He had joined in the past, but since the talk was going on, we could not welcome him. So I would like to welcome him now. Just 5
Yes,
minutes.
please.
Okay.
Okay.
Pawan ji, please focus on Mr. Lokhandwala.
Sure.
Okay. I think he's traveling. He has. Hello. Pawan ji.
Pawanji, focus on him.
Focus on
Yes.
Merunissa and yeah.
We got
Good
him.
evening, sir.
Yes.
We want to welcome you. Sorry you had to wait and you have to go for your own meeting today. I would like to introduce him. He is our guest of honor for the day. He is district chairperson for diabetes, Lion Muhammad Lokhandwala. He is a chartered president of Lions Club of Bombay, JJ Crescent, which is 31 years old and was started with 110 chartered members. Mr. Lokhandwala, because I think you all must be knowing, he's a very famous builder, as also an industrialist. In spite of his busy schedule, that is today his club has a physical meeting at Diplomat at 7 p.m. He agreed to be present and he was present amongst us, but he joined a little late, so I could not introduce him. We welcome him also and thank you, sir, for attending. If you have any question for the doctor, you can put it forward, sir. Mr. Merunissa,
Please unmute yourself. Mohammed Bhai, please
please
unmute
unmute
yourself.
yourself. If you have any question for the doctor today.
Please unmute Merunissa ji. Please unmute.
Unmute yourself.
Not unmute.
We cannot hear. She's not unmuting.
Please unmute. Merunisa ji,
Pawan
please
ji, you
unmute.
can unmute her. Please do
No,
it.
I cannot unmute.
Okay.
Verunisa, unmute yourself, please.
She cannot
Unmute yourself.
hear.
Yeah. Okay. Fine.
Yeah,
Yes. Yes. Now
yeah,
you
Now you
speak.
can
Verunisa, would you like to say something, ma'am?
Yes. Why we get diabetes in children also nowadays?
Yeah, this is a good question. See, in children, so there are two types of diabetes that we see in children. One is the type 1 diabetes, which is in which we see in younger children, in which because of an autoimmune reaction, most commonly, your body's pancreas stops making insulin. Now that is a long term. That's a type 1 in fewer in younger children is what we see. That for that the treatment is usually insulin for a longer period of time. We have a few tests to confirm whether this is an autoimmune type of type 1 diabetes. There are certain antibody tests as well as a test to see how much insulin your body is making. If that insulin is less and the active, this usually happens in younger, as young as even 6 to 7 years old children sometimes get this. And it's actually, even for, because the patient has to be a child has to be on insulin long term. One of the examples, there are a couple of examples for this amongst little popular people is uh, so this is type 1 diabetes. Type 2 is something we are seeing type 2 diabetes also in teenagers, mainly because of childhood obesity is what we are seeing. So I've seen patients as young as 16 to 17 years with a typical type 2 diabetes, which is an adult onset. Earlier was only correlated with uh, the age of above 40. So the management of both types is different. If it's type 1, it's insulin, it's a little more taxing for the family, for the child, but eventually the child becomes very particular from a younger age. And we see some of these children either becoming extremely brilliant because they're so, they're so focused from a very young age. Imagine a 10-year-old taking insulin by himself, managing his diet or her diet, or they become extremely spoiled because the family goes into a complete thing that this guy's got this at a very young age and it becomes very pampered. So it's either an autoimmune reaction, which is your body's own immunity fighting against you, or it's childhood obesity because of the factors where lack of sports, lack of exercise, a lot of junk food, and a part where there is a family history, so some genetic component. So that is childhood diabetes.
Okay, doctor, but I saw one child born baby got diabetes and he became the cockeye. Why it was like that?
Sorry, he became?
He became cockeye. He couldn't see with that eyes. One
Yes.
eye.
So so that is neonatal diabetes. That is immediately after birth. That is that is something also which is related to this autoimmune condition. It's very, very rare, but it does happen in certain conditions where what we see more. There are two things in neonates. We either see a hypoglycemia, that's low sugar because if the mother has diabetes, or very rare cases we see neonatal hypoglycemia, which is also an autoimmune condition. So
Okay. Okay.
it's more to
Thank you,
do with
doctor.
yeah, welcome.
Can I
Okay,
ask one
thank you.
question?
Yeah, please.
So, doctor, we are usually told to test post lunch 2 hours after food. Now, what should it be exactly 2 hours after food? What is it? And why is it only 2 hours?
So earlier, when we do an oral glucose tolerance test, so when earlier what we used to do, we used to give 50 or 75 grams of glucose. We used to test at 1 hour and 2 hours. It is said so 1 hour and 2 hours because of the peak of the meal. So whatever meal you've had, it goes into your stomach, gets converted into glucose. That peak is between 1 and 2 hours, and also your body's own insulin response to cover that peak. So if it's a meal very high in sugar, you've had 2-3 gulab jamuns, the body will need to secrete more insulin in response to that. And that peak coincides at 1 or 2 hours. So it's 2 hours from the start of the meal, but 1 hour 45 minutes to about 1.5 to 2 hours is a good period to get the complete peak of that meal. So it coincides with the peak. That's why.
Thank you.
Hello. Hello.
Yeah, Mabad bhai बताइए.
Yeah.
Yeah.
I just want to
Yes.
ask you simple question. That
Yeah.
every time we are measuring the blood glucose by one instrument, which I have also distributed to about 50 people now in
Yeah.
my project, Acquisition monitor, blood monitor.
AccuCheck.
Accurate.
So is it okay once we are checking it, it gets correct result, whatever it is showing?
Yeah. So, see, what we do at home is a capillary blood glucose. We do it from the finger. So it's the smallest capillaries at the end. So there is big artery cap.
Yeah,
What we what we do what we do in the lab is from the vein. So there is a 10%. There can be a 10% gap. AccuCheck. There are
okay.
3 or 4 very good machines which come, and AccuCheck is one of them. But I just tell my patients that whenever you do a laboratory test, once in 3 months or once in 6 months or once in a year, you take your machine to the lab, or at the same time you check your sugar in the lab. So a 10% error is acceptable. Some people say, okay, this came 150 and in the lab it came 135. So why is such a big difference? But that's a 10 to 15% difference is acceptable because the type of blood is different. The capillary blood has a little more glucose than the blood from the vein that we take in the laboratory test. So it is accurate. The machine you've mentioned is also quite good. I use that in my clinic and it's quite accurate. But it needs to be just calibrated once in a while. Not a must, but it's better if it's done. Patients are more confident about checking it then.
And sir, what is the maximum after the food? What should be the maximum diabetes number?
Maximum acceptable, the higher range you are saying, right? For
The
a
higher
normal.
means, suppose actually I have checked also my diabetes. The minimum is coming about 60 and maximum is coming about 100 only. So it
Yeah,
is okay
so
after food.
are you on
Pardon?
any medications, or you are just checking it as a routine? You are not on any medications, right?
No, that's all.
So
It is
in that
routine I am
case,
checking.
yeah, in that case, fasting anywhere between 70 to 99, even less than 70, sometimes it comes about 65, 70. That is okay. So 99 or less fasting, and any random or 2 hours post meal of
Yeah.
100 to 140 is absolutely normal.
If it is coming after the food, 80 or 90, then
So in some cases, what happens, because there is a component called insulin resistance. So whatever insulin your body makes, your body demands a little more to digest that amount of glucose, and hence when your body has the capacity to make that insulin, it tends to make a little more, and you see that your post meal levels is less than 100. So overall, it is absolutely fine if you are not on any medications. A post meal
yeah.
level of 90, 95, sometimes 80
Okay.
is okay. If it goes
Okay,
below
okay.
70, then we need to look into other things, that why is it going so low. But the levels you are mentioning are okay.
Okay, thank you very much, sir. 1 minute.
Doctor,
Yeah.
hello. Doctor, some
Yeah.
people get in
Yeah,
urine
please.
this sugar.
Yeah.
Yeah. So how
So
to check that?
urine sugar. So after the renal threshold, that's the urine threshold for sugar is 180 milligram per deciliter in blood. So as long as your blood sugar is less than 180, it will not
Okay.
usually spill over in the urine. Your kidney will be able to reabsorb that. But once it goes above 180, there is a chance that there will be some of it which will spill over in the urine, and that's not good because it kind of overburdens the amount and the capacity of the urine to manage that sugar in and out, and hence, so that is the urine sugar level. Earlier it was detected when we did not have the blood tests easily available. I was not even probably born then. It's more than 40 years ago.
Yes,
That time
yes.
diabetes was diagnosed.
I'm talking
One
about
of
50 years back story. Because the
Absolutely,
people
that
used to see their urine in the one test tube, and they used to
yeah.
make it hot and putting some something chemicals. Then they used to make it hot, and they used to see all
Mhm.
that. Yeah. So is
Yeah.
it
So
it was the correct this thing that
yeah, so at
what
that
they were doing?
yeah, at that times we did not have the advanced, the more accurate blood test. So we used to rely on the
Right.
urine test. urine
Okay.
sugar is how much, and then we had the strip where we could put it and see how much sugar was there. Also, one of the most common modes of diagnosis of diabetes was when patients used to, when patients used to say that wherever I urinate, especially in people who use common toilets, where
Yes.
3 or 4 houses are sharing a toilet, and that is where it used to happen that there used to be ants near the urine.
Okay.
Wherever a person used to urinate, there used to be ants. That is a very common mode of diagnosis, probably not in the high-rise buildings where you have your own bathrooms
Yes.
and
Very
multiple
true.
bathrooms in one house, but in places where there are common toilets, where someone used to then
Okay.
figure out that who had gone last, and then tell him go and check your sugar because these ants gathering around the urine. So that is another thing that comes to mind with
Oh,
urine.
okay. Okay.
Thank you.
Thank you, doctor.
Yeah.
Yeah.
Yeah,
क्या बोल रहा था तू?
doctor, one question from me.
Yes, Mr. Agarwal. Please.
Fasting sugar is high, say 140, 145,
बढ़िया.
Hmm.
but the after food it is also 140, is normal almost. Huh?
Hmm.
How you explain this?
So, so I'm kind of considering this is in someone who is uh, who's not on any medications for diabetes. So, I mean, I'm considering this case as you're saying. So, what
Yeah,
happens is when you're sleeping at night or when your body is fasting, as I said, there is a concentrated form of glucose that is stored in your liver, and that. So when your body is fasting beyond 4 hours, because 4 to 5 hours is the maximum amount, even if it's a very complex meal, that the meal will give you energy in form of glucose. Beyond that, when you are sleeping and you're fasting for 8 hours, 10 hours, 12 hours, or 14 hours, how much ever time from your last meal at night to your first meal in the morning, your body tends to sustain the function of the kidney, the function of the brain, partly by giving glucose that it has stored for these times. Now, how much glucose that body should be giving to the blood or to these organs in the fasting period is also controlled by insulin. So if there is some mismatch there where your body is not adequately producing enough insulin at night, then your fasting sugar can go up. So that is it's a very common. Sometimes we even see a fasting is slightly higher than the post lunch, because the post
yeah,
lunch the post lunch, what happens is uh, there is an extra stimulus. Your food is stimulating to secrete more insulin. Your food is stimulating your pancreas to secrete more insulin. Whereas when you're fasting, the pancreas has to somewhat adjust by itself. So in layman's terms, I can explain it that way, and that is how there's a little bit of insulin, the insulin control over how much glucose your body that it has reserved for these times, how much it is giving. वो ज़्यादा दे देता है in simple terms, and the insulin is unable to control how much it's giving. So that's a reason of higher fasting sugar. So it is possible.
it requires treatment.
So if your fasting is 140 and your post is 130, for example,
Yeah,
then what we do is we see your HbA1c, your 3 months average. If that
okay,
is not very high, then we decide. So ways to manage fasting sugar is a good evening exercise routine can help reduce your fasting sugar. Effective stress management can, and there are certain medications that. So if your HbA1c is high and we feel that this is impacting your overall health, then we may take a decision to first put you on certain, like an evening exercise routine or something that can help reduce your fasting sugar, and check again after a month or two and see. It's not very dangerous because it's just a 20 to 30 points higher than the borderline level, and your other readings may be good throughout the day. So we see the HbA1c, which is the 3 months average, and then we take a call on whether it requires management. So whether it requires medications or not is the question.
yeah. Thank you very much.
Okay. I think you'll have to unmute yourself. Someone, I think Kashmira is speaking. Please unmute yourself. Miss Kashmira.
Unmuted.
No,
Must be Kashmira Meromji. If you want to ask any question, unmute yourself, Kashmira.
कश्मीरा जी अनम्यूट कीजिए.
Kashmira Meromji, unmute yourself.
But
लेफ्ट
if she
साइड में
can't
माइक
hear,
वाला बटन दबाइए. लेफ्ट साइड में माइक वाला बटन दबाइए कश्मीरा जी पहले.
But can she hear you?
He's
वो बोलते जा
talking.
रही है.
Kashmira, unmute yourself, then talk. We can't hear you.
We can't hear you. अनम्यूट कीजिए. लेफ्ट में एक माइक जैसा बटन है वो दबा दीजिए.
Tell her like this. Tell her like this.
No, she can't see.
Can't do, she says.
If she can see.
Yeah.
Yeah.
Yeah. Oh, again she's
Again.
muted herself. Please unmute. That red thing should go.
Doctor,
No.
average age in our club is 70 years.
No, but still you all are doing extremely well, I must say. I'm as good. I'm very bad at technology. Every time I have to give this, the stress and diabetes was a lecture for me myself because I had to check 2-3 times. I do that before every lecture. Sometimes, last moment pe kabhi, I think she did that. She unmuted in between, but again mute ho gaya. That red thing should go away.
She must have pressed it twice, na? So mute
Yeah.
होके वापस हो गया वो unmute.
Maybe she can text the question to one of you all. WhatsApp it to someone and they all can read it out if
somebody can talk over mobile.
Just the crux of the question, so I think she can hear us, so she can at least get the answer. Phone pay.
Now she's unmuted.
No,
again.
Not again muted.
Again
I
mute.
think
Now she's
No.
pressing twice, so she gets unmuted and then again muted.
muted, yeah. That red thing should go away.
એને કે એક જ વખત
Press
ખાલી
only
દબાવો.
once. Kashmira ji, press only once. Mic button.
She can't hear.
Can we send a message to her?
Kashmira, તું unmute કરીશ તે 2 વાર ના પ્રેસ કર, એક જ વાર પ્રેસ કર. નહીં તારા પર અહીંયા મને દેખાય છે ને તું મ્યુટેડ છે. અનમ્યુટેડ નથી. આ જે ઉપર ક્રોસ દેખાય ને
red line.
તે બાર meaning it is that is muted. તે તું હવે પ્રેસ એક જ વાર પ્રેસ કર તો you'll be able to talk. Okay, I'll talk. પણ તું ટ્રાય કર મ્યુટ કરવાની. ઓકે, અનમ્યુટ કરવાની. ઓકે.
No, awaaz આવે છે પણ
So
બહુ ધીમો આવે છે.
Kashmira says her fasting sugar is always high than the post meal. Why so?
Yeah, exactly. So similar question to Mr. Pawan. So we divide this answer into 2 parts. One is those who do not have already diagnosed diabetes. First time you are testing and it's come high and again it comes marginally high. So sometimes what happens is fasting is 110 and post is 105. So you feel fasting is higher, but both are essentially in a normal range. Fasting is probably in the borderline range, but it's normal, right? It's normal for this age. Another question is if fasting is 170 and post is 140, then post is normal, but fasting is actually in a diabetes range by about 50 points. So then we need to check the HbA1c, which is a 3 months average, or check the fasting again. Sometimes we ask patients to do a sugar level at night and see at what time it's actually spiking up, whether there is any change. So that is, we need to take it into context. There are cases where fasting comes higher than post lunch, but if both are almost in a normal range, so bahut chinta nahi baat nahi, you are both are almost in the normal range. You just, as I said, food stimulates more insulin secretion, and that's why sometimes post lunch is slightly on the lower side because of that stimulated insulin, whereas fasting, that stimulus is not very strong, and it may so be. But if it's in a significantly higher level, then yes. Second part is when people who are on medications for diabetes and then this happens, then we need to adjust the medicines accordingly, that the fasting comes lower slightly and the post lunch doesn't go very low. So those who are on medications, those who are on insulin, we need to adjust the doses to ensure this this reverse type of report doesn't keep coming. But those who are not, then it depends. If it's in the normal range and this pattern is there, it's okay. If fasting is actually in the diabetes range, we need to investigate further.
Any more questions? Jaru? Any more questions?
No more questions. If there are no more questions, you can give a vote of thanks.
Yes.
Anyone? હર્ષાબેન તમે એકદમ મૂગા છો કઈ કેવું જ
એને બી mute થવાનું હશે.
અનમ્યુટ કરો અનમ્યુટ કરો અનમ્યુટ કરો હા બોલો
ક્વેશ્ચન નથી પૂછ્યું.
નથી પૂછ્યું.
અચ્છા ઓકે ઓકે
ઓકે
Firuza, you can give the vote of thanks.
Yeah, at the outset I thank the presiding officer Jaru. Then I thank Dr. Saglani. It was really a very interesting and you explained it in a very simple manner. We have heard many such talks, from other doctors, but half of it goes above you. But you explained it in a very simple and convenient, very convincing manner, I should say. So I'm sure all understood it, I'm sure. So we once again thank you, all of us thank you for that. And I'm sure everyone got quite some knowledge on the subject.
Definitely.
I think
Yes.
half of us are already suffering from diabetes due to the old age, not the type 1, I think. Anyone type 1, I don't think. We always have type 2 or due to the age related. But but still it was very interesting. Only one last question, Mr.
Yes.
Deepak, he said he couldn't talk on the line. He has put a question. One second, I'll read it out. He says, diabetes is a serious issue with vivid patients. What specific precautions can be taken by them? 2 of my close friends are on ventilator support because of diabetes.
Yes, so that is true. Diabetes is complications of diabetes are can be serious, can be like so. Right from recovery from an infection, which is also we have seen in case of COVID-19 also, patients who are not well controlled prior to getting COVID infection have had a more severe course of disease. And unfortunately, some of those whom we've lost also, the proportion is slightly higher in uncontrolled diabetes. That's not to say that, people who have diabetes or uncontrolled do not survive this. I don't want to put that message. 99% patients, 98% patients are sort of surviving this, and we don't need to get scared. We just have to take those precautions. But recovery from any infection, whether it's COVID, tuberculosis, pneumonia, any other bacterial infection, any urine infection, it becomes difficult with a higher sugar level. So that's one which is in infection cases where patients may go into a more severe course of condition. There may be more generalized sepsis, and there may be a adverse outcome with the patient. Second is related to cardiac comorbidity. So as I said, that's a more spectrum where there are bigger arteries in the heart, where blood pressure, family history of heart problems, younger age of onset of heart disease, diabetes, and cholesterol and stress levels. So all of these combined can cause. So diabetes is again a player there, where strokes and heart attacks, as we say, it has some contribution. But in that, I would say that obesity and blood pressure, good control of blood pressure has as important, if not a more important role than management of diabetes. So it is a serious condition if the complications happen. And hence we were at a time 20-30 years back where we did not have this much authentic research. We just had a couple of medications. We did not know that we could actually reverse diabetes, scientifically proven. So we did not have it. Now we are in a much better place to manage it. But I would still say that we need to prevent. So at every point, there is a prevention. Either you prevent diabetes or you prevent the complications. The first thing would be to prevent diabetes. The second step would be to prevent complications. If you get complications, then the next step is to manage it. So as I said, there are infections, more severe course, more likelihood of getting a heart condition, if especially duration and uncontrolled diabetes, blood pressure, these are bigger. So it can be life threatening in some cases, the complications of diabetes. But if it's well managed, then most people tend to have a very favorable outcome, even if they get a bigger complication.
Thank you. I'm sure there are no more questions. Once again, I thank Dr. Saglani.
Thank you very much.
Even all the members. I'm sure all members are satisfied.
Yes.
Pavanji,
Yeah,
what would you
all
like
are
to say?
satisfied.
No, thank you very much. It was very good.
Thank you. It was
Thank
really
you,
an
thank you.
interesting session. Thank you, Jaru, for bringing him.
Thank you, Dr.
Thank you.
Saglani, for accepting our invitation.
Thank
Thank
you
you.
very much. This is a pleasure to interact with such an energetic crowd. I would say, it's very rare that we have people so involved. And I wish you all the best. And just take care. If there is any question for me, you all can send it to anyone. I think Pavanji or Ms. Jeru has my number, and I'll be happy to answer it later on.
Okay. Thank you very much.
Okay.
Sir, where do you
Thank
have
you.
your
Thank you.
dispensary? Where do you have your dispensary? Your clinic?
So I'm attached to Apollo Spectra Hospital in Tardev, next to Sardar Pav Bhaji. So that's where I consult. That's my main place, and I do online consultations. I also go to Ville Parle and Kandivali, but because of COVID, I'm avoiding the suburb patients are managed online. But physically, I go to Tardev. That's the one place where I've been for 5 years, and that's where I am in South Bombay. And I also go to one center called Om Diagnostic Center in Baikalla West, where I see patients for very less cost. So we see patients for 350 rupees, 300 rupees there. So if there's anyone who kind of is not cannot, so we do good work there. Even follow-ups are only 100.
Thank you, doctor.
Center,
Thank you.
as well as there are some doctors attached to it. Yeah.
Thank you very much,
Okay.
doctor.
Thank you very much. Take care.
Thank you.
Thank you.
All the best.
Thank you.
Thank you, doctor.
Thank you.
Thank you very much.
Now we can continue, rather start our meeting.
Take care.
Just for
Bye-bye.
10 minutes. Jaru wants to, because she has got to address the crowd, inform the members.
So we just want to say what we did between last meeting and this meeting